This is part 2, and we're going to start again at the section titled Birth and Symphyseal Diastasis Joint Mechanics. And I will just start at the section which talks about the actual mechanics. And the X-ray studies prior to 1958 suggest that the mechanism that increases the pelvic outlet is accomplished with sacral nutation, in which the top of the sacrum moves down and forward, and the bottom of the sacrum, called the apex, moves back and up, allowing an increase in the anterior to posterior pelvic outlet dimension. There's also a medial infolding of the ilia, coupled with upper pubic joint compression and lower pubic joint widening, along with spreading of the sit bones, which are the ischia, and that increases the medial to lateral dimension. I'll demonstrate that in a short while. This normative birth model is supported with benchtop ligamented pelvic modeling, affirming it to be the most efficient way to increase pelvic outlet dimensions up to a specific limit. And I'll demonstrate that with this pelvic model. And we spoke of the sacrum that moves forward at the top, and you can see that the bottom of the sacrum and the coccyx moves posteriorly, so that increases the anterior to posterior dimensions of the pelvic outlet. And there is a medial infolding of the ilia, and so there's an upper pubic compression, there is an upper sacroiliac compression, a lower sacroiliac distraction, and a lower pubic distraction. And trying all types of configurations, applying forces, reveals that that in fact is the most efficient manner of enhancing the pelvic outlet. Please do ignore the metal here and this piece up here. I'm using this on a research project, and so that's just not relevant. So let me continue reading this. Several case studies from the orthopedic and obstetric trauma literature on obstetric pubic symphyseal diastasis present X-ray and CAT scan images. And we've already seen those images on figures 2, 3, 4, and 8. The images show a novel, unreported posterior glide fixation of the ilium or ilia, in addition to the reported pubic joint and sacroiliac joint widening. The ilia make novel, unreported contact with the sacrum in the retroarticular space, which contains the interosseous ligament. I'll review those figures with you in a little while. And so what this does is it shifts the load bearing posteromedially behind the actual joint. The novel behavior was replicated with benchtop modeling on a ligamented anatomical model, and it is detailed under the section Diathesis Theory. So I'd like to show you a couple of those images. So again, when the pubic joint separates beyond 10 millimeters, it meets the definition of pubic diastasis, which there's considerable separation, considerable instability, and we did show an image in which there's an X-ray here, 47 millimeters of widening on day 1 related to birth trauma. And here is an image in which you see that novel behavior that I spoke of, in which the sacroiliac joint widens. And this is the true joint. And in the postero-inferior margin, you get compression. So it's a very peculiar behavior in which the inferior and posterior space behind the true joint actually now compresses and functions as a new joint, creating stability. This image is remarkably unstable because there is considerable widening at the SI joint, particularly on the right side here. And you can see that the ilium on the right has glided posteriorly, or you could say the sacrum has glided anteriorly, more so on the right, which would be a rotation. Regardless, there certainly is considerable increased width here and instability, but you can note that at least on the left side there is some compression here in the portion of the joint that normally is wider because it's full of the interosseous ligament. So we will now talk about diastasis theory. It appears that in preparation for birth, there is a normative spreading of the pelvic joints with an upper limit to the degree in which the pelvic outlet dimension cannot be further increased. The upper pubic joint and the anterosuperior sacroiliac joints are maximally compressed, restricting any further motion, which occurs primarily in the frontal plane. At the onset of obstetric pubic symphyseal diastasis, the symphysis ruptures and separates, potentiating and inducing a novel cam-like trajectory, which is primarily constrained to the transverse plane. This phenomena has not been reported in the literature. The ilia compress behind the true articular portion of the sacrum, creating stability via a novel, non-cartilaginous articulation. The next topic is diastasis recovery. In order for the pubic joints to approximate and heal, it is necessary to reverse the traumatic obstetric pubic symphyseal diastasis trajectory. Otherwise, it appears to be physically impossible for the pubic joint and the sacroiliac joints to fully approximate and heal. It is theorized that a symphyseal gap may persist in those cases that fail to fully recoil and heal. In the chronic population of obstetric pubic symphyseal diastasis, orthopedic manual physical therapists, women's health physical therapists, etc., may be able to evaluate and identify a lack of anterolateral glide of the ilia and medial ischiopubic compression. Initial intervention then should be directed at restoring motion and facilitating stabilization and healing with a passive prolonged fulcrum with a force applied, and also with use of a trochanter/pelvic binder rather than being applied higher up as in a traditional sacroiliac support. The next section is trochanter binder replaces sacroiliac support. The trochanter or pelvic binder is an orthopedic standard of care for acute obstetric pubic symphyseal diastasis, and the same is true for traumatic pubic joint diastasis. Note that significant compressive reduction going from 4.7 to 1.5 centimeters has been reported in the acute phase in a very short time frame of 4 days. So this person had 47 millimeters of separation, and they applied a trochanter belt compressing the lower pelvis. And this image is actually taken 6 months later, where it's reduced to 15 millimeters. But an interim image was not available, but it did, the published study did indicate that it reduced to 26 millimeters in the short course of 4 days. Research indicates that the typical application of pelvic or SI belts above the trochanters is not as effective as application applied directly at the level of the trochanters for obstetric pubic symphyseal diastasis. And I will stop here, and in part 3 we will put some images up and elaborate on that. Thank you.